Yeah. So, do you want to do this? Or do you want me to start it? Okay. Like.
Okay.
No, we don't have to share. When you do it, you can share. I will. Okay, I am going to. Where is it? Where is it to share the screen? No. He is here to share, but we don't need to share now. Okay. I will share for you later on. Okay. Okay, all of you. I had the last week I had a 44-year-old gentleman who came to me with a complaint of voice loss. So when you hear voice loss, the first thing that you will think of is a recurrent laryngeal nerve palsy, which is a branch of the 10th nerve, vagus nerve. Now, the interesting thing about this man was that his first episode of this voice loss was when he was 11 years old. And then he had it when he was 22. Then again, when he had it when he was 39. And now he's 44. It again. 4 times voice loss. And along this time, along with the voice loss, he had severe pain, which was suggestive of glossopharyngeal neuralgia. So he has been seen by many ENT surgeons in India, but because of the severe glossopharyngeal neuralgia, it was thought that this was just not a simple recurrent laryngeal nerve problem, and it was referred to us. So the first thing that struck me was that this man's 9th, 10th was involved. So usually you would think 9th, 10th, if the 9th, 10th is involved, you would think first it is the nucleus ambiguous which is involved, so probably a brainstem problem. Second thing, you would think about a jugular foramen where 9, 10, 11 is involved. So these were the 2 things that I thought about. So I looked for long track signs, any motor problems, anything which is involving the brainstem. There was none. Then I got another interesting history from this patient, that he also used to have hypotensive episodes, and sometimes he used to miss beats, which means our doubt towards nucleus ambiguous is strengthening, because 9, 10 with heart abnormalities was strengthening. So it could be either nucleus ambiguous, or if it is nucleus ambiguous or anything near it, why would he develop problems at 11, 22, 39, 44? Probably something which is recurring like MS, but MS affects white matter usually. ADEM, maybe something like that. Otherwise, a tumor cannot stay on and produce symptoms like that. So an infarct obviously cannot do that. So we were we were very clear that it was just not a recurrent laryngeal nerve palsy or even the jugular foramen, because his 11th nerve, his shrug was okay, very good shrug. So trapezius and sternocleidomastoid was completely okay. And then we looked at his palate. The left palatal arch was down. Now, looking at this, we thought, since other than the nucleus ambiguous, the only thing that could be involved was the 9th, 10th in the subarachnoid space. Sometimes what can happen is the 11th nerve, after it exits from the brainstem, it goes down and then it comes up. So the 11th nerve could be spared actually. So unless it is a jugular foramen. So what we did is we did an MRI with angio, 3D cyst, and we saw something interesting. Maybe Andrea can talk about this MRI.
Yes, it was seen a big vascular loop from the left
Left
pica and the vertebral artery, and
left vertebral.
yes, left vertebral artery, and the left vertebral artery is dominant. The right vertebral is very small, and it has a long course in front of the brainstem, and in the fiesta sequences, you can see that the 10th and 9th nerves are dislocated medially, and they go form a big loop in front of the brainstem from this big ectatic, I would call it, vertebral artery. So it appears to be a case of vascular compression, similar to trigeminal neuralgia, similar to glossopharyngeal neuralgia, and that is the reason, because 11th nerve is paired. So because we are proximal to foramen jugulare, and the 11th nerve take an inferior loop before going into the jugular foramen. So, and now the patient is doing better.
Yeah. So the patient is now doing better, but we have advised, if it happens again, then we have advised vascular decompression. We thought it was interesting, so that is why we wanted to press.
Do you have the image to show us, or you don't have it?
You have the image shared.
You see, this is the jugular foramen of the left side, and this is the actual loop that the vessels are taking.
I'll show you I'll show them the TOF.
Yes.
They can see.
Yes.
Can they see the vertebral artery?
You see how big this vertebral artery is?
Yes, we see conflict.
Okay. And it's pushing. Oh,
So,
yes, maybe this.
Yes, conflict. Yeah, conflict.
the vertebral artery here.
Yes.
The vertebral artery.
Can you see the vertebral artery? See?
Yes, the right vertebral artery is much smaller.
Yes.
And
I think it is better
On this.
on your second screen. We don't see good please, here it is better.
I can put it onto the second screen. 1 second.
Okay. Yeah. Yes. Now it is good.
Okay.
You can see that?
Exactly. I see the conflict.
So I will show you on the axial. See the huge vertebral.
Yes. Yes. Yes.
That's a huge vertebral artery.
Yes. I see the conflict.
So that is an unusual case of glossopharyngeal and 10th nerve palsy.
Nice. Thank you for sharing.
Okay.
Do you use sometimes combine approach with microvascular and endoscopy to done decompression of neurovascular?
Did you hear the question? Okay.
I say, do you use combine approach with endovascular and please endoscopy and microsurgical with microscope?
Till now, I have only used the endoscope to just see after I have done the surgery. I have never used the endoscope to do the actual surgery. Till now, I have been very comfortable with the microscope, so I generally do not use an endoscope. But maybe in the future, this is something that I am looking at, that if I have a 3D scope, then maybe we are looking at exoscopes and 3D scopes to do this surgery.
Yeah, microscope. Okay. Because in my department, sometimes we use the both. We use the endoscope to see correctly because you know with endoscope you have good view about the anatomy, and then we put microscope to go to do dissection and to separate the nerve and the artery, and to put Teflon between the two. We usually we use that. Yes.
Go ahead. I'm sorry. I accidentally muted you.
Okay.
Okay. Any other comments or questions from the panelists? Ali, do you have anything to say? Dr. Weil or Zolo? Any comments? Okay. Well, very good, gentlemen. How do you like the Momo? Are you eating Momo?
He hasn't tasted the Momo till now.
Okay. So I survived on Momo when I was in there in Nepal.
The dumpling.
The dumpling. No, I haven't had it yet, but I'm here for.
Well, try it. It's excellent. So, okay, very good. Any other comments or closing comments or whatever? Okay, Iype, what's your schedule this week? What are you going to do this week?
Yeah, so any surgeries, any interesting surgeries this week, we will put it up. We are having a festival season, so the surgeries are a bit less, but if there's anything interesting like yesterday's case, we'll put it up.
Yeah, well, it's great. Not only great teaching, it's good to show people what you're doing up there. And this is Andrea's second time in Nepal, correct?
Yes, it is.
Okay, so it must have been worth it the first time. So thank you very much, gentlemen. You guys have a great day, and thanks to the panelists.
Thank you, John, and nice days and.